Hi, my name's Nancy Poole, and I'm the director of the Center of Excellence for Women's Health and the prevention lead for the CanFASD Research Network in Canada. And this is to introduce you to a series of presentations about research on FASD prevention. So this series shares brief explanations of what we know about FASD prevention from those who are currently conducting research from a number of countries. And the goal is really to make this research accessible and to inspire people to take up the findings in both practice and policy. So you can see we have 5 sections in this series, starting with presentations about stigma as a central issue in preventing FASD, then offering some frameworks for FASD prevention, then looking at what we call level 1 prevention in Canada, which includes broad awareness raising, health literacy, and community-led health promotion efforts. Then looking at what we call level 2 prevention in Canada, which is brief alcohol interventions plus integrated support and referral as needed with all women. And finally, levels 3 and 4 prevention, which is about engaging and assisting pregnant women who use alcohol or are trying not to, and who face related health and social concerns. It also involves supporting new mothers and their children to build on the gains they've made to reduce or stop drinking in pregnancy, to support them to improve their health and their social status, to support attachment and promote assessment of children's health. This last section of the series looks at research about specialized holistic support of pregnant women with alcohol and other health and social problems, as well as research about postpartum support for new mothers in recovery and their children, which are both areas where much more research is needed. We look here at the work of 2 Canadian research teams studying the work of community-based programs for pregnant women and new mothers. And these programs really focus on relational and holistic approaches that really expands the territory of FASD prevention work into maternal health and child health programming.
Good day. My name is Carol Hubberstey, and together with Deborah Rutman, as part of the Nota Bene Consulting Group, we're going to present today a brief description of a national evaluation of programs that work with pregnant and parenting women with substance use and complex concerns. What we're talking about are the reasons for seeking help and the most significant changes that the women said occurred as a result. We have a colleague, Marilyn Van Bibber, who's also part of this study, and Nancy Poole from the Center of Excellence and her team, who are also part of the team and of the study. It was funded by the Public Health Agency of Canada and took place between 2017 and 2020. Next slide. The Co-Creating Evidence Project was so named because we worked together with the 8 programs that were part of the evaluation. These are 8 different programs who were serving women at high risk of having an infant with FASD or prenatal substance use. And the reason was to both bring them together and to share promising approaches and practices and to evaluate the effectiveness of multi-service programs such as theirs. You can see here in this slide where the programs were located. There were 3 located in BC and Victoria, Vancouver, Surrey, 1 in Alberta, 1 in Saskatchewan, 1 in Manitoba, 1 in Ontario, and 1 in Nova Scotia. They are, again, I stress, 8 different programs, so they don't all use the same approach or same model, but they were all working with the same groups of women, same women, and they all volunteered to take part in this study. We visited the programs twice over 18 months. We interviewed 256 clients in total and staff as well, 108 and 60 service partner interviews as well. We collected data for 18 months. The programs collected on our behalf, quarterly program and output data and client intake and snapshot data. But today we're talking about the interviews that we had with the women about their reasons for taking part in the programs and what they got out of that. The first thing that happened is that we gathered together the programs, their leaders, their managers, their staff, in a meeting where we talked about, and they came to an agreement about what were the approaches that were the most important ways in which they had of working with the women. And you can see those across the top. In essence, they said by employing these approaches, that they were relationship focused, that women centered, trauma informed is very important, culturally grounded. They used a harm reduction approach, a lot of kindness and compassion, and a multi-service interdisciplinary developmental lens. And then by undertaking all of those activities, not necessarily all programs undertook all activities, but those were the key activities that at some level were important to most of the programs, or that these outcomes at the bottom would occur. And so that became the theory of change that we were working with in creating the evaluation. We asked women what they hoped to get from participating in their program. And remember, for women who are prenatal substance using, the reasons for doing so are complex and often driven by a host of social determinants of health factors. And you can see that in the reasons that they articulated for what they were hoping to get. They wanted support for their problematic substance use. That was the most important thing. Another very common theme was they also wanted support for child welfare and or the mother-child connection, followed by support and information for pregnancy and help getting stable housing. And also, surprisingly, they really wanted some healthy social peer connections and support. Many felt very isolated coming into these programs, and they didn't have a lot of support in their lives. These, as you can see, are intertwined. They're hard to tease apart. One kind of leads into the other. The support for problematic substance use often connected to wanting support in addressing child welfare issues. When we asked what their most significant change was, again, you can see very strongly interconnected themes. Not only that they relate well to the reasons why they came into the programs, but they relate well to each other. Again, many felt that they had quit, reduced, or safer substance use, that harm reduction approach, and they attributed that to the support they received from their program. As a result of that, they also felt that they had strengthened mother-child connections. Many women said that they had been able to go home with their infant, their baby, and or they had also managed to have other children that had been removed earlier in their lives to be returned to them. Once they regained that stability and support in their lives, they were able to get their children back. And you can see the other themes there are increased support, safer, improved housing, and increased connection to community, family, and peers are all part of that getting their children back. This slide is just to say, in addition to those, there were those strong themes, there were other themes that again reflect the social determinants of health needs, and including stronger social connections, reduced isolation, and increased support.
Hi, everyone. So we created this slide through the as a result of the interviews that we did with clients, with staff, and with program partners. And really what it's showing is that array of supports and services that are part of these wraparound programs. As Carol said, the women are coming in, the they're coming in with a variety of needs, of issues or concerns in their life. And these show you all the different ways that programs can be supporting them. When we created this slide, we were never intending to suggest that any given program needed to offer all of these different types of supports and services. But as you can see, by putting this out there, this shows the different examples of ways that even within a given area of support, such as basic needs or food and nutrition or cultural programming, for example, that the different programs are offering these types of supports. And they're offering them not only for the women, but for children as well. And as you might have seen on the previous slide, one of the outcomes was that parents are feeling that their children are benefiting. And so not only is there that mother-child connection, but there's supports being offered and developmental assessments and health supports and services for the children as well. So we just wanted to leave you with some practice implications from our study and from the use of wraparound programs for pregnant and parenting people and their families. And so from our co-creating evidence study, we have learned the importance of the one-stop wraparound services that offer this array of services through which people can come in and access supports in relation to health, prenatal care, housing, substance use, and social determinants of health, such as food and nutrition. But once there, they're able to get the whole array of services that they and their children may need. The programs, the foundational to them are the knowledgeable and empathetic program staff. These are program staff who really deeply understand the issues, they have training in these issues, and they practice those, they employ those approaches that Carol talked about when she was talking about the theory of change: trauma-informed, harm reduction, culturally grounded, women-centered, and the kindness and compassion. There are well-conceptualized, evidence-based theoretical foundations of the programs, and strong partnerships were truly essential in enabling the programs to allow them to provide the services and supports that they offered. Many of them had very strong Indigenous cultural reconnection emphasis, both through the programming on site and through their relationship with partners, and opportunities for community and peer support, often that lasted even beyond the terms of the programs themselves, as women were transitioning into the community. So if you're interested in finding out more about our project, you can download the report, the executive summary, or any of the 2 pages that we wrote on the project. They're available in both English and in French. And feel free to contact any of us, Carol, Marilyn, and myself at Nota Bene Consulting Group. Our email is listed there. Thank you so much for your attention. Bye for now.
Hello, my name is Mary Motz. I use she, her pronouns, and I'm a 5th generation settler from Central Europe. As such, I'd like to express my gratitude to the traditional inhabitants and ethical caretakers of the land that I live and work on in Toronto, or Toronto, which is covered by Treaty 13 and includes the Anishinaabeg, the Huron-Wendat, the Haudenosaunee, and the Mississauga of the Credit. I'm a mom of 2 amazing adult children, and most relevant for this webinar is that I'm a clinical psychologist from the Mothercraft Breaking the Cycle program. Breaking the Cycle is an early intervention program for infants and young children who are at risk for poor mental health and developmental outcomes as a result of maternal substance use and related factors. The core funding from our program is through the Public Health Agency of Canada's Community Action Programs for Children and the Canada Prenatal Nutrition Programs. We are a level 3 FASD prevention program because as part of our core service, we provide a pregnancy outreach program. The Breaking the Cycle Pregnancy Outreach Program supports pregnant people who are homeless and using substances to become connected to instrumental supports, medical and addiction services, and to improve outcomes for the pregnancy and for parenting. We are also a level 4 FASD prevention program, as we provide comprehensive services for women and their children ages 0 to 6 years in order to mitigate risks related to maternal substance use and to support positive outcomes related to maternal health, well-being, parenting outcomes, and as well, child development outcomes and well-being. This slide helps to support an understanding of the context of risk for families who attend services at Breaking the Cycle. These are all factors that impact the neurodevelopment and mental health of infants and young children. The mothers who attend Breaking the Cycle experience the same risks in their own childhood, but receive no intervention or adequate support to overcome these conditions, which include maltreatment, parental addiction, mental illness, family violence, isolation, and many other traumas. The mothers at Breaking the Cycle were the children that we see in the program. In order to prevent and mitigate the impact of FASD, we use a relationship-based early intervention approach as an opportunity to break the intergenerational transmission of trauma to the new infant. Breaking the Cycle is delivered through a cross-sectoral partnership with 8 partners in our community that deliver services that our families need, including medicine and addictions medicine, mental health, midwifery, public health, probation and parole, child welfare, and child developmental services. The issue of engagement for women who use substances and removing barriers to care is critical for this population of mothers and children. Women are often understandably fearful and mistrustful of professionals and systems as a result of their previous interaction with professionals, as well as within systems that have perpetuated stigma and/or the longstanding impacts of colonization, genocide, and slavery. Many mothers who attend programming at Breaking the Cycle have lost custody of other children due to substance use and related issues. The aim of Breaking the Cycle is to be able to engage women in a different kind of experience in their pregnancy or with their new children to be able to receive early intervention services to improve parenting and child development outcomes. As a result, we deliver Breaking the Cycle as a single access model to promote engagement. Instead of mothers traveling to multiple organizations and programs for the services that they require, they come to one location and the professionals travel to deliver services. This enhances access to services for the family. The program space is non-institutional, warm, welcoming, and safe for both mothers and children, so it promotes engagement. With our community partners, we deliver services for mothers, including addictions and mental health counseling, services for children, including childcare, developmental programming, as well as a pediatric and FASD diagnostic clinic. Additionally, we provide a range of parenting services to support healthy attachment and a positive parent-child relationship. We also, very importantly, offer a core component, which is basic needs support. We have nutritional and food supplementation, so we serve meals and provide a food bank. We offer clothing and diapers, and we supplement transportation costs to facilitate access. In addition to center-based services, we offer a home visiting program for each family, as well as a street outreach program directed towards homeless pregnant people who are using substances. Program evaluation and research has been an important part of the Breaking the Cycle program over the last 25 years. It has helped us confirm the efficacy of the program, as well as to make changes to services based on the needs of families. Our early evaluations confirmed that through our use of theoretical frameworks and our program model, that we were successfully engaging pregnant people and mothers who were struggling with addictions and working to parent their infants and young children. We have demonstrated that longer engagement in programming leads to a more comprehensive use of services, treatment goal completion, maintenance of recovery, and custody of children. Additionally, when people were engaged earlier in the pregnancy, they were more likely to connect with a range of community services, as well as to have better birth and perinatal outcomes for their children. When we explored parenting outcomes for breaking the cycle mothers, we found that participation in programming was related to significant outcomes in many areas, including reduced parenting stress, increased sense of parenting competence, higher quality attachments, improved social supports, and a greater connection to services in the community that families require. Over the past 25 years, there's been a global shift in our understanding of epigenetics, neuroplasticity, and the impact of the postnatal environment on the developing brain, especially in the first 3 years of life. This has been extremely important in the area of FASD and in the opportunity that we have in the early years to circumvent, and in many cases prevent, some of the secondary disabilities that we used to see as a foregone conclusion of this diagnosis. Early interventions that support the healthy attachments with a caregiver and provide developmental and FASD assessment and intervention for infants and young children have led to typical developmental trajectories for many breaking the cycle children, even though there has been prenatal exposure to alcohol and other substances. In solidifying our understanding of outcomes for the well-being of mothers, we had the chance to compare domains of change over time for women who attended programming at Breaking the Cycle with another addictions program in our province that does not use the same relational approach in promoting early parent-child attachment and supporting child development outcomes. We found that although women from both programs improved in their addiction-related goals, that it was only the women at Breaking the Cycle where we saw significant decreases in mental health symptoms and a significant increase in their capacity for healthy relationships. Finally, we more recently had the opportunity to share and evaluate an interpersonal violence intervention that we developed to Breaking the Cycle with 43 communities across Canada through a 5-year initiative. From our experience in partnering with so many amazing communities who support families who have been marginalized, we solidified our learnings in the following areas: about the need to respect women's readiness for change, to always prioritize the safety of families and of the service providers who work with them, to make the time to build relationships and to support engagement, to collaborate within prevention programs, but also with other services across the community that families need, and to respect community wisdom through partnerships, research, and evaluation. To conclude, our experience as an early intervention and a level 3 and 4 FASD prevention program at Breaking the Cycle, this has highlighted the importance of fostering relationships between mothers and children, between program staff and families, and between programs within the community as a necessary and effective way to create an opportunity for families to grow and thrive. Additionally, prevention programs need to consider developmental and attachment-based interventions to mitigate the impact of prenatal substance exposure to infants and young children, as well as trauma-informed and harm reduction lenses to support pregnant people and mothers to develop trust, to engage, and to utilize the services that will support their capacity to parent, as well as their own well-being and positive outcomes. Thanks so much for sharing your time with me today.
So, thinking about this research on specialized holistic support during pregnancy and after delivery, the wraparound programming that was described in a national study of 8 Canadian programs serving high-risk women, I think is really interesting in how they describe using a common theory of change. And that research really identifies what women hope to get from participating in the program and just how well aligned that was with what women described as their most significant change. So it really helps us understand the importance of listening for what women see as important and getting behind that. And the Breaking the Cycles work that really focuses on mother-child programming in the postpartum period is interesting in how Dr. Motz describes this as a relationship-based service that reaches and engages really high-risk mothers and their children through both pregnancy outreach programming and early intervention with children. And linking and integrating that program has really meant for some very positive outcomes for both women and children. And she describes the benefits of including and integrating developmental, attachment, trauma, and relational theory-based approaches. So thinking about this research on holistic and specialized support for women during pregnancy and postpartum. The national study of the 8 Canadian programs serving women at high risk of having alcohol-exposed pregnancy used a common theory of change, which was interesting in that the programs weren't identical, but were working from this common theory of change. And that research really identified what women hoped to get from participating in the program and how this aligned well with their most significant change. And I think that gives us a really good idea about listening for what women say is important, that they wish to and are ready to do, and guiding and walking beside them in achieving those changes. Dr. Motz describes a relationship-based service in Toronto that reaches and engages high-risk mothers and their children through pregnancy outreach and early intervention programming. So linking those two aspects of programming for mothers and children. And their research identifies outcomes for women and children and the benefits of theory-based programming, including and integrating developmental, attachment, trauma, and relational theory-based approaches. So really interesting to see this focus on how we do very complex work that draws from multiple theories and traditions and links programming for mothers and children together. And I think can be really inspiring for the work of us in the prevention field, thinking about the mothers at highest risk and the mothers who we need to continue to support after the pregnancy. So if you're interested in discussing the implications for practice and policy, we are really encouraging you to contact the researchers who presented and/or those of us at the CanFASD Research Network. Thank you for your attention.